All right, great. So good. Again, thank you so much. And I'm going to be talking about diversity and implicit bias, a little bit about microaggressions, and some of the things that we've done within the Department of Medicine, as well as the School of Medicine, to help improve diversity, as well as the issues dealing with microaggressions in training programs. Let's see. Next. Okay, there you go. I don't have any financial disclosures for any of the topics that I'll be discussing today. All right, and this is I wanted to start with a case presentation. This is something that was mentioned to us by the medical students, and based on their feedback, we were able to create a case to highlight some of the issues, some of the things that the medical students, as well as the residents, have experienced as they go through the training. So as I go through the talk, I want you guys to think about some of these things and how you would respond to them as well. So let me see, this is on my screen. There you go. All right, so hopefully all of you guys can read it, but basically it reads, E is an internal medicine intern halfway through her internship. One of her patients just underwent placement of a drain by IR to treat an abdominal abscess. E goes to see the patient to assess his overall status post-procedure to check on the drain's output so that she can report back to the team and then sign out to the night coverage intern. E knocks on the patient's door and says, "Good afternoon, sir. How are you feeling?" The patient initial response, "I thought I told him I didn't want anyone to looking at like you taking care of me." Thinking the patient was embarrassed to be examined by a woman because of the location of the drain, E responded by saying, "My apologies, sir. I did not know you had requested not to be seen by a female provider." The patient responds by saying, "Does anyone listen? I didn't say anything about females. I just don't want anyone of your kind taking care of me." E responds by saying, "Understood, sir. I will have my team send someone else to take care of you. But I'm afraid that may be some time because they're all busy at the moment. Have a good day." And afterwards, E ends up having some second thoughts, some regrets, some sentiments of what to do about this particular situation. All right, so think about that as we go through. And this is just a breakdown of the learning objectives. I want to discuss why diversity is important, addressing the implicit bias and as well as microaggressions, how to enhance diversity in our training programs, as well as the impact of faculty development, community involvement, and outreach activities, as well as sustainability. All right, why is it diversity important here at UCSD and in general and academics? Well, it's a diverse learning environment. It increases the trainees' exploration of diverse perspectives. It also helps reduce the level of racial prejudice, as well as increase the tolerance of alternative point of views. It also helps leverage the talents of individuals from all the backgrounds. And it helps bring perspectives as well as experiences and scholarly interest to help enhance and improve the quality of the research as well as the educational experiences. And last but not least, diversity is part of the UC's fundamental mission to serve all of our members of our community. All right, so let's take a look at the breakdown of diversity and in our community. So this is just something I got from the website, from this government website for 2018. And as you can see, over 50% of the population are classified as non-Hispanic white, in particular 60.4%. That is followed by the Latino community or Hispanics at 18.3, and afterwards is the African American community at 13.4. All right, so that is actually quite different than what we see here in California, right? So as you may imagine, about 39% are Hispanics, followed by non-Hispanic whites, which are 36.8, and then a smaller proportion of African Americans. Now, San Diego, it's somewhat in the middle of the two. You still have a pretty large proportion that are considered Hispanics at 34%, followed by non-Hispanic whites at 45.2%, and the African American community at 5.5. So this is just to put it into context of diversity. Now, I included the demographics of Imperial County, given that we provide so much care to members in that community. And as you can see, 84.6% are considered Hispanics, followed by non-Hispanic whites at 10.4, and a small fraction of other racial and ethnic groups. All right, so that was racial and ethnic variability. How about income? Well, when you look at the breakdown of median household income, you see that in general, California is much higher than the average for the entire US. However, when you look at San Diego, it's much higher compared to any other groups. And look at the disparity or the gap between Imperial County as well as San Diego County. And when you look at the poverty levels as well, not surprisingly, Imperial County has a much higher level of poverty compared to San Diego, California, and in general, the US. All right, so this brings us back to UCSD, particular or Hillcrest Medical Center, which is or safety net, right? We provide surrounding areas such as East San Diego, Imperial County, as well as other diverse communities such as the LGBTQ community. We have Owens Clinic, right? And we'll also provide great deal of service to patients with disabilities and immigrants and the homeless population. So we got to take that into consideration when we're making some of the determinations of diversity and inclusion. Well, we know that we live in an environment that is relatively diverse. So how can we take care of this diverse patient population? Well, there's been several studies to highlight some of these things. This was published in the New England Journal back in 2004. It was a cross-sectional study of over 150,000 visits by Black Medicare patients, as well as white Medicare patients that were older than 65 years of age. And one of the highlights of the study is that Black physicians were more than 40 times more likely to see a Black patient than a white physician, right? And so this highlights this type of concordance between the provider and the patient. Also, Black physicians reported greater difficulty in getting their patients seen by a high quality subspecialist. This is a different study from JAMA in 2014. And what they ended up doing, they looked at the association between different racial and ethnic groups of providers as well as patients. And what it highlighted here is, if you look at the Black patients were more likely to be seen, about 23 times more likely to be seen by a Black provider. How about Hispanics? Hispanics, very similar as well. 19 times more likely to be seen by a Hispanic provider. In Asians as well, 25 times more likely as well. Now, it also looked at language, and not surprisingly, non-English speaking patients were more likely to be seen by also another provider who spoke the same language. This is another study in which they ended up randomizing the patients to providers. And one of the things that, this is out of Oakland, and they wanted to see if patients received different care depending on the type of provider that they saw. And what they realized is that Black patients were more likely to talk to a Black doctor about their health problems when compared to a white doctor. Black doctors were also more likely to write additional notes about their patients. And they identified that cardiovascular diseases impact was significant, leading to approximately 19% reduction in the Black-white male gap in cardiovascular mortality. Also, diabetes, cholesterol screening, and invasive testings were up 20%, right? So invasive testing in this case was colonoscopy. So you might imagine that patients felt more comfortable hearing from a provider of similar race or ethnicity to say, hey, it's time for you to get that screening colonoscopy check. And there's also an increase in the number of flu shots among Black patients. So again, all this highlights the importance of diversity and the concordance between the patient and the provider. Now, why is diversity also important, especially in academics and in residency programs? Well, part of it is because the ACGME has made it a requirement, right? So if you look at the guidelines and how they're going to be evaluating programs, it basically states that there needs to be a systematic recruitment and retention of a diverse and inclusive workforce of residents, fellows, faculty members, as well as staff within the academic community, right? And the ACGME will look at some of these things as well. Now, we were fortunate that Dr. William McDade, who is the first appointed Chief Diversity and Inclusion Officer, happened to be in San Diego a few weeks back, and he was able to make a little bit of time during his trip to give us a short presentation on diversity and inclusion within graduate medical education. It was, like I said, a very ad hoc event. We were still able to advertise it among the medical students and some of the residents. It was relatively straightforward for those who were working at the VA to just walk over the bridge, since it was a 7:30 a.m. event, and he highlighted some of the work that he's been doing and how the ACGME will be working with different programs to help improve diversity, inclusion, and retention of a diverse training faculty. So some of the things that he highlighted are things that we're already doing here at UCSD. He talked about continuing with the outreach and recruitment of underrepresented students, improving the pipeline, right? And here at the School of Medicine, we have several programs already underway. We have Doc for a Day, which is a program where students from underrepresented high schools come over to the School of Medicine and have a chance to work on the SIM suite. And they basically are taught how to use the ultrasound, how to look at the organs, how to do CPR, how to suture and sew things together. So it's really exciting for them to see what is it that you'll get a chance to do once you enter medical school. We also have another program called Healthy Minds and Healthy Bodies, which is this program right here. And that's actually a medical school elective for first-year medical students, in which the students go to Lincoln High School, for example, and they teach several courses in health sciences. We also have med students for social justice. So this is individuals who are interested in pursuing the social determinants of health and how we can communicate that more effectively by approaching leaders in Sacramento or in downtown San Diego, how to provide Medicare for all, for example. That's one of the things that they're working on. The Border Health Project is another large group of our medical students and residents where they are working with immigrants and asylum seekers as well. And then we'll have the Lincoln Health Equity. So basically this is a mock MMI. So for those of you who are involved with the admissions process at the School of Medicine, the students go through multiple mini interviews. So this is a mock interview, so they get familiar with it. And HPrep, which is the health program for retention and exposure. Basically, this is a little bit more broadly speaking, in addition to getting students interested about medicine in general. This is for other health sciences fields such as pharmacy, nursing, so that understanding that people are interested in health in general, but not necessarily medicine. So again, trying to look at different aspects of it. All right, how does bias affects diversity, right? So it's important. So now we understand the importance of diversity, but how do we actually move the needle, right? So we need to be aware of biases, right? And bias is defined as when people sort data into categories and rely on schemas as well as shortcuts in order to organize information. So you can have bias that can be explicit or implicit. Explicit is the conscious feeling, attitude, or behaviors in which you maintain and are easily question or adjust a particular train of thought that you have. Implicit bias would be unconscious, unintentional, that may be in direct opposition to one's conscious belief, yet it leads to you to provide information about a particular person over a period of time. It's important to realize that everyone has implicit bias, right? So if you hear someone says that they're not biased, that they're wrong. We all have some degree of implicit bias, and you just need to be aware that that exists, and we just need to do something about it, right? So it's often operating outside of our awareness, right? That's why it's implicit. It is based on stereotypes as well as attitudes that we hold and tend to develop early in life, and they tend to strengthen over time. Right? There's been several ways that we can look at this in terms of how implicit bias can perpetuate health disparities. And basically, what this diagram shows is that if a provider has implicit bias, you can go multiple routes, whether it's path A or path B, and yet somehow you're gonna try to rationalize your implicit bias so that you make it think like you don't necessarily have a bias, and yet that will lead to a health disparity. Well, how do we manage implicit bias? Well, the important thing is to do awareness and recognize that you have implicit bias, right? And this is what I was saying before. Those who think they're immune or don't have implicit bias are the most likely to be affected by it. And realize what are your biases, right? And one of the things that we ask our residents as well as our fellows is to go through the UC learning module on implicit bias, which is helpful. Also, it's important to understand what influences your biases. Is it the interpersonal communication? Is it team participation? Is it the personal evaluation? And then try to flag your awareness so that you realize that you're stereotyping or making this type of assumptions, right? So think about certain keywords, for example, saying that, oh, you know, this person is articulate, this person is pushy or unreliable. Or when you say, I got a gut feeling, I just know something, right? And trying to selectively justify it. So all those are signs that there may be an underlying implicit bias going on. Also, there may be external factors that pushes an individual to be more susceptible to implicit bias. And these factors include time pressures, right? So if you're busy, you're getting multiple consults in the ER, and you're looking at this person who looks older, disheveled, you may start assuming that they're homeless and they're using drugs, when in fact that may not necessarily be the case, right? There may be something else. So time pressures can certainly play a role. Stress, other distractors, right? If you have issues going on at home, or someone else in your service is not doing well, hunger, temperature, self-imposed deadlines, all those external factors can make it easier for the implicit bias to kind of creep in and make some changes. All right, so how do you manage the implicit bias? As I mentioned, being mindful and conscious and doing debiasing, and also questioning yourself and your criteria and assumptions. And just think about this, when you're kind of going through it, do a self-check analysis and think, well, does my patient's race or low income status actually translate to poor compliance or adherence to the treatment? Think about whether or not you're speaking in a certain way to a non-native English speaking patient, because you assume that they don't understand due to their accent. And you think about whether or not it's truly a language barrier, right? Think about, are you judging this applicant based on legitimate criteria that matter? Or is it just my comfort level or familiarity with their background, therefore the likability, right? So this is in-group bias, right? So I'm Mexican-American. If I meet someone that is also Mexican-American that is interested in the type of foods that I eat, the soccer, for example, I enjoy watching soccer. If I find someone like that, find something common, am I more biased towards that person? So those type of things, we need to keep that in mind, right? Another helpful tip would be to do counterexample exposure, or what's called stereotype replacement. So, which is basically seek out examples that help contradict your bias, right? So once you start thinking about what may be affecting you, then you start thinking, for example, an example would be Muslims, right? You may start thinking, well, is there a particular way that I view Muslims? And then can I find someone, whether it's a colleague or a celebrity or a politician, that will help bring down that type of stereotype? And then eventual repetition. As you keep doing these types of exercises, your brain will try, or at least try to unlearn the patterns that you've learned over time. All right, another tip would be perspective talking, and that is just realizing that walking a mile on someone else's shoes is important, at least to realize that, right? To practice empathy. And then another tip would be individuation, which is viewing the people that you work with, the patients that you see, your colleagues, as individuals, not necessarily part of a stereotype group. And obviously it doesn't help to make more diverse friends, right? So exposure and developing counterexamples, as well as the intimacy of those relationships, can go a long way of bringing down some of those behaviors, those exposures that people had when they were younger. And then lastly, seeking feedback, right? So if you're really honest to yourself and you think that there may be something going on with implicit bias, talking to a friend, someone who you can confide with, just ask them, it's like, hey, what do you think about how I approach this particular person? And then getting that type of feedback would be helpful. Another way that we look at implicit bias, and this is more for our residents and our faculty, is using the implicit association test, right? So we provide some of these lectures to our residents in internal medicine, and we ask them to go through the IAT. And basically, the implicit association test is a method to explore hidden biases that we all carry from a lifetime of exposure in cultural attitudes about age, gender, race, ethnicity, religion, social class, sexuality, disability status, nationality, all these different things. So this has been well documented, and they're available for free, basically, right? So what we do for our residents and our faculty during our sessions, we ask them to use the QR code and then go through it, right? So sometimes to save some time, we ask them to do it beforehand, and they end up going through the exercises, and then we get together in small groups either after a lecture like this one, and then do some debriefing and see what they experienced, what were the results. And basically, I don't know if you guys are familiar with these tests, but basically it looks at the association of your response time between multiple things. So for example, in the example that I gave you would be signs and male, right? And it would be young and positive are assigned to the same response, right? And then you look at signs and female and see what type of response you get with that. So they're looking at the ability to respond to certain cues, and the longer you take to respond to something, then it suggests that there's maybe a less of an association between the two. So that, for example, associating signs with male providers and females with liberal arts. All right, so in something related to diversity and implicit bias, it's important to discuss microaggressions, right? And the reason this is important is because it's frequently based on our implicit biases. Microaggressions were first described as subtle, often automatic, non-verbal exchanges that infringe on our personal space, energy, and mobility. This is from Dr. Chester Pierce from Harvard University. Over time, that definition has expanded, and now it includes brief and commonplace daily verbal, behavioral, as well as environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative slights and insults that potentially have harmful or unpleasant psychological impact on the target group or person. From Dr. Daryl Sue. This is a campaign that happened at Harvard. I'm not sure how many of you are familiar with it, the I'm Harvard. And this was basically to help address some of the issues related to microaggressions and implicit bias at the university. And as you may imagine, it's not difficult to see how if they see a young Black man with earphones thinking that he's listening to rap, right? So in this case, he's holding a sign that says, no, this is not rap. And then this is an African-American woman saying when she was told, you're lucky to be Black, so you can get into college, right? And there's another woman here says, having an opinion does not make me an angry Black woman, right? So these are stereotypes that sometimes people have about certain groups, and these are considered to be microaggressions, right? So so that's the definition of microaggressions, and all of us can can come up with some examples as well as that we've seen in our personal lives as well as in the hospital setting. However, what are other examples? Well, these are some of the examples that we collected from our residents. And one of them was, oh, what are you, right? And this was a mixed race individual, and they weren't sure exactly whether they thought that the person was Black or white, you know, and that's offensive. And then asking, no, really, what are you from? And can you tell us what Black people are thinking of this topic? And that's also another important one, because it makes the individual presumptively a expert on that particular field and representing a particular group. Another one would be, but you don't look or act gay. Another one would be raising your voice while speaking to a person with visual impairment, or assuming women wearing scrubs in the stethoscope are nurses, not doctors, and demeaning assertive women as loud or bossy, but men being strong leaders. Complimenting how good someone English is or how articulate the person may be can also be considered as a microaggression. So what are the typical responses in those settings? Typically, at first, when you hear something like this, you're shocked or you're silent, and you don't know necessarily how to respond, right? You may fear being considered overly sensitive, right? People are like, oh, you know, just being political correct, right? The person may also feel like that may jeopardize the treatment, the alliance, the working relationship that person has with a colleague or with a particular patient. Therefore, we need to be aware of this, right? It's been documented that society expects that the healthcare professionals act with humility, respect, and forbearance far beyond what is considered normative for many other professionals, right? So we got to be aware of that. And if you're the person saying some of these things, sometimes we get defensive, may end up having some guilt or embarrassment. And sometimes we may not necessarily be aware of some of the things that we're saying. Now, there are codes of conduct for the patients as well as medical staff, and we need to be aware of those as well. Well, how do you manage the microaggressions? Well, first of all, it's important to call it out, right? So if you see and you experience something like that, then just call it out, and this will be helpful because I'm sure other individuals may be experiencing the same thing, right? So try to have no arguments, no apologizing or negotiations, right? If we're the perpetrator, acknowledge and apologize what happened. Learn and teach responsive scripts, right? We think that this is also can be helpful. So be prepared. So if you encounter something similar, be ready to deliver that, right? Because at the moment when that happens, like I mentioned before, a lot of times we go into silent mode, or we try to justify it or ignore it, right? So have a response can be helpful. And then try to be to the point, measure and uniform. And so these are some of the examples that they've been reported in some of our students that we taught, or some of our residents and interns. And that is, for example, that statement was hurtful, and we don't tolerate that kind of speech here. We respect you, and we expect you to respect each other. And I'm fully qualified physician, able to take care of my patients and lead my team. And I think you're trying to compliment me, but I feel uncomfortable and would like to focus on your health, right? So these are examples that our residents can use and have used when they're talking to some of their patients. And I have to say that usually some of these occur to our female residents and interns, typically when they're at the VA. It's just a different culture, but it's important to speak out and mention some of these things. All right, so we talked about calling it out, learning and teaching response scripts, also debriefing after the encounter. It's important as a team leader to be aware of these things, right? The attending needs to be notified, or if you're the chief resident or the senior resident in the team, check on the safety and emotions of everyone in their group. Everyone can respond differently, and I think it's the responsibility of the leader of the team to be aware of these things. Acknowledge what went well and what went wrong or what went poorly, and make a plan and commit to it so that another situation occurs, you can do something about it. All right, so this is the case that I first presented at the beginning, right? So, and again, this is one of the learning cases that we provide to our medical students and our residents. So obviously there were multiple microaggressions, or what you may consider to be macroaggressions, right? And these are the type of questions that we ask or trainees to think about when they go through the presentation, and then just identify the microaggressions, whether more than one, how did this make them feel, right? Talking about some of these things in the open can be quite helpful. And then you go through it. All right, so now what are some of the strategies that we can use to improve diversity and target implicit bias in the residency? Well, I think it's important to bring invited guest speakers or what we call diversity champions to the campus, engage the residents and medical students, both at regional and national conferences, implement residency recruitment events, socials, for example, establish diversity interview days, do outreach to pre-meds, as well as the medical students locally. And what we've done in the Department of Medicine is establish a visiting elective scholarship program to help encourage individuals from underrepresented backgrounds to come to UC San Diego and experience for themselves what it's like to be a resident here. And then lastly, community and engagement. All right, so over the last 6 to 12 months, what we've done, these are some of the speakers that we brought to the Department of Medicine. Kendrick Juru, he's a professor at UCLA. He does a lot of work with underrepresented groups, and as well as uses telemedicine to help reach those individuals that are harder to get a hold of, and also helps with medication non-adherence compliance issues. He's African American. Claude Yancey, who is the Vice Dean for Diversity and Inclusion, also the Chief of Cardiology, Northwestern School of Medicine, was here. And Lisa Richardson, who's a Director of the CDC, Division of Cancer Prevention and Control, was also able to give us her own experience of what it was like growing up being African American and being able to go through academics, and now leading a large branch of the CDC. Now we've received the support from the chair of the Department of Medicine, Dr. Dillman. And so typically what we do in these cases, these individuals get recruited to come and give grand rounds. And usually the night before or the morning of their talk, we set up these small groups with our residents, medical students, fellows, basically staff, who want to just connect with this individual and hear this story, find out how they got to where they are now and how they could potentially help those individuals move a little bit forward. We have also done outreach to our own faculty and our residents, and that is by promoting them in the website. As I mentioned, the elective scholarship program, diversity days, and the community engagement refugee clinic with Dr. Julie Sierra. So this is what we've done in order to help promote some of the faculty. Some of you are likely familiar with Dr. Gabay at the VA, as well as Dr. Tony Lopez. Again, both of them are tremendous allies when it comes to diversity and inclusion. And in order to highlight some of the work that they've done and making themselves available to those individuals who not only work here at the university, but also potential trainees, right? So third and fourth year medical students who are looking to potentially come to San Diego, they want to see who potentially can be their mentors. And then also important to highlight the work that our own trainees are doing. So we added this section to our site, to the website, so that we can highlight the work, for example, that Maggie's been doing, as well as Carlos Lagos Hernandez. Again, so that, again, or medical students or trainees can see all the wonderful things that everyone is doing besides taking care of patients. We also did the implementation of the Visiting Elective Scholarship Program, and this is a next fourth-year medical elective, so that fourth-year medical students who are from underrepresented backgrounds and are interested in coming here to San Diego, they can actually come here. It provides a $2,000 stipend to help cover the tuition fees, transportation, lodging, and we also provide a faculty and a house staff mentor so that it can help them throughout the 4 weeks that they're here. this is something that we felt that was important to do because we heard that from the students. I've gone through several national and regional conferences such as LMSA and the SNMA, the Student National Medical Association. And many of those students that I met with them, they were asking to see if there were any scholarships that would allow them to come to UC San Diego and experience firsthand what is it that we were doing here. And because of the cost of paying tuition, all these different things, they just sometimes they couldn't find the money to just leave their home institution and come to San Diego. Now, this is a program that that other medical centers have available. So we felt that we needed to get back to the same level as other institutions. For example, UC San Francisco, UCLA, UC Davis, and a lot of the programs in the East Coast, such as Hopkins, they have these visiting elective scholarship programs for URM applicants. And we felt that if we wanted to compete and help bring more diverse applicants to the campus, we needed to do something like this. So we approached this idea and discussed it with Dr. Dillman, and he was able to make it happen. Now we normally give out 1 to 2 scholarships per year, and we were totally open to the applicants about this. And last year when we started doing this, we received about 9 applications. And I expect this year to be a little bit lower, given what's happened with COVID-19 and emails that I've been getting that elective rotations will not occur until September. So that will affect the number of applicants and students that we get here. All right, so this is just a snapshot of our elective scholarship program, just the website, what it looks like. And then the students can just kind of read through it and apply. It's a fairly straightforward application. They just type in all their personal information, why they want to come here, what electives they want to do, some demographics, as well as some of the circumstances that make them from a disadvantaged background. And once we receive all these applications, we establish a committee, and we go through them, score each of the files, and based on their interests, coming to San Diego, reading their essays, and then we assigned certain points, and then whomever ends up having the best score sheet ends up getting the scholarship. So yeah, so again, thanks to Dr. Dillman for the scholarship money to make this happen. All right, so we continue to promote the Visiting Elective Scholarship Program at regional and national conferences such as SNMA and the LMSA conferences. We also promoted that in the electronic listservs for many of these affinity organizations, and social media such as Twitter and Facebook as well. Now, I received multiple emails about this, and I believe now the Department of Emergency Medicine has their own elective scholarship program. Other things that we've done is outreach to our own medical students, such as the SNMA group, LMSA, the LGBTQ, APAMSA, and Students for Social Justice. We helped establish a peer-near-peer mentorship program. This is in conjunction with the Office of Diversity and Community Partnership. And the goal is to provide information, advice, encourage the students, and provide a positive role models, right, as they go through the medical training, the clinical years, so that they can start seeing themselves as belonging here at UCSD. Community engagement is very, very important. I cannot stress this enough. I've gotten a lot of good feedback from the students when I see them at the regional conferences. For example, we went to UCLA with a group of students, and the year after that, we went to Stanford. And that was very rewarding for us, for students, being able to get some of the time off and attend these conferences. That was very rewarding for everyone. Also attending the American Public Health Association conference, which is here in San Diego a couple of years ago, was very important. And participating in local activities such as tearing down barriers to care, right? It was a rally for Medicare for All. That was important. Doc for a Day, as I mentioned, exposing high school students with medicine, and our residents have also contributed that as well. So they serve as mentors for the medical students who are providing some of the teaching. Other activities that we got involved include the Hispanic Heritage Month, Black History Month, or MLK Day, the Asian Pacific Islander Heritage Month, and an American Indian Native American Month celebration. So all these things are usually happening in the main campus at the Price Center, and we like to participate in those activities. This is just a picture of our residents with the medical students at the School of Medicine. This was the regional SNMA conference, and there's Maggie there, for example, and these are our medical students that are part of the SNMA association here at UC San Diego. This is a couple pictures, some pictures from our event that we had in Philadelphia. This was the national SNMA conference, or the annual medical education conference. And there you'll see, again, Maggie, again, huge help in terms of recruiting efforts. Dr. Jassel right there talking to one of the applicants that was trying to obtain more information about our program. And here we got some medical students as well, just talking to the other students, trying to learn more about San Diego. And these are some of the images of our guest speakers. This is Dr. Michelle Alpert, who's a cardiologist at UC San Francisco. And she's very much involved with the Association of Black Cardiologists. She's the current president of that group. And these are our residents, medical students, and fellows who attended one of the talks that she gave here. Now, we were given the interest, the broad interest between our residents and the medical students, we created what's called the AHEAD interest group, which is Advancing Health Equity, Advocacy, and Diversity, so that we can actually do some advocacy work. So some of our students have actually have gone to Sacramento and done some advocacy at the Capitol. And then there's the other group called Advancing Women in Medicine, again, trying to help improve some of the issues related to the lack of representation by female providers in academic medicine. And finally, this is just another shot of our recruiting efforts at the APHA, which is one of the largest public health events. Oh yeah, and lastly, this is the Medicine in Motion event that we had in conjunction with Dr. Daryl Moyer, who is the CEO for the American College of Physicians, as well as Dr. Tammy Lin, who is the local person for that. And this is basically, it's a mentoring program for young girls who are interested in medicine. So, but this just highlights the partnerships that we've developed over the years. And it's great to have the backing of the ACP. All right, so how did this translate to what we're doing in medicine, right? So we realized back in 2016 that there was an issue with the number of women in our residency program. Dr. Jassel was very proactive about this. And she approached me with this issue, the fact that less than 30% were female, and this was happening over a period of time. And we sat down and started developing strategies to help combat some of these things, created the Advancing Women in Medicine group, and bringing speakers as well. And as you could see, that over the last 3 years, there's been a positive trajectory in terms of the representation. And looking at, in general, for the categorical internal medicine training program, very similar issues, lack of representation in our house staff. Back in 2015, 2016, we decided to implement some changes, as I said, some of these partnerships that we talked about. And luckily, over the last few years, we've seen, again, a positive trajectory for that as well. So these are some of the steps that we've taken over the last 3 years, and it looks like things are moving in the right direction. So we still got a lot of work to do. These are what I like to call action items. So we need to continue our partnerships with the school of medicine, as well as the affinity organizations, and continue our outreach with the San Diego community, as well as the Office of Diversity and Community Partnerships, helping promote lectures and workshops in diversity and inclusion, and then also collaboration with the Center of Excellence in Health Equity, which is something that it runs through the Department of Family and Preventive Medicine. And also partnerships with the School of Public Health, right? Now that that's formally happening, using our resources together so that we can bring speakers, so we can bring critical mass between the students there at the School of Medicine, or residents, the students at the School of Public Health together, so that we can do more activities together. And then again, growing the AHEad committee. None of the work that I've done so far would be possible without the support of Dr. Dillman, Dr. Jassel, Maggie, Dr. Ma. They've been tremendous allies. Everyone in the Department of Medicine, as well as the School of Medicine, PRIME, and the Office of Diversity and Community Partnerships. Also, I wanted to mention the Office of Faculty Affairs. They've done a tremendous job at the faculty level, trying to recruit and retain faculty as well. All right, so yeah, some more pictures, but happy to take any of your questions.
Dr. Castellanos, this is Rich Gallo, and thank you very much for a fantastic lecture. You really crammed a lot of information, facts in there, so I'm glad we recorded it, because I think I'll be listening to it again. So moving forward, given the pipeline limitations that we have, do you recommend that we focus on any particular stage of training to increase diversity amongst our residents as well as faculty, or do sort of a multi-approach, try to do everything at once?
That's a great question, and it kind of goes. I didn't really go into that level of detail because the Office of Faculty Affairs has taken the lead on that. But so when it comes to faculty, Dr. Trejo and Vivian Resnick, they've been working on that. And what they've done is look at the numbers at each of the different departments, right? And they compare that with the diversity within that group when it comes to the residents, so they can see whether or not you have a good number of representation within the residents or within the faculty. I don't have access to the other department besides the Department of Medicine. But I think you just have to look internally and look at what your program has, what the department has. For example, for medicine, what we realized is that we lack diversity within our training programs. So we decided to tackle that issue first. And that's why we decided to partner with a lot of activities with the School of Medicine, because we realized that many of the students at UC San Diego's the School of Medicine were not necessarily coming to our training program. And we needed to find out why that was the case, right? So helping improve the pipeline to the residency program, that was important. Now, what we're doing, after doing that for 2-3 years now, what we're working on is on retention, right? There's a big push of increasing the number of primary care providers within UCSD. So see if we can help compete against the Kaisers, the Scripps, the Mercies, the Sharp, so that we can help retain those trainees that we're doing an excellent job of getting them trained to stay here and be part of the faculty. So we decided to focus on the trainees first, and then now we're working on the faculty aspect of it.
I just want to mention, people are raising their hands. Please use the chat function. There are some questions for Dr. Castellanos that have come up from the chat. Dr. Romero said, is the 12% current level on the graph shown for house staff and in medicine here at UCSD showing minority representation?
Sorry, Jessica, can you repeat that question again?
Is the 12% current rate on the graph shown for house staff in internal medicine here at UCSD showing minority representation? I think it's asking if the 12.
Yeah,
if it's
so that's
12.
Yeah, so I think that's one of the last slides. Basically, yeah, that's the representation for the categorical internal medicine class. Yes.
Dr. Boyko said Dr. Olenberg and I did a skin cancer screening at Vista Community Clinic in October, and to our surprise, it was part of a bi-national health week. Excuse me, it jumped. Of which one of the co-sponsors was UCSD Health. So it's an interesting comment. And then Dr. Nelson, please talk about separate interview days for URMs. I would think that this might be a little ill-advised.
So, what we decided to do is we have a certain number of faculty that are URM, right? And making themselves available to the applicant pool would be helpful. We found that would be helpful, right? So not only to interview the applicants, but also get a chance to talk to them and share experiences. Since we interview so many applicants, since our program is larger than most programs, we decided to just identify certain days that would work for certain faculty, so that faculty that are interested in diversity and inclusion issues could put it in their calendars and say, hey, you know what, that day I'm gonna make every effort to be here in San Diego so that I can not only interview the applicants, but maybe meet them during lunch or something like that, so we can share information, right? So that's the main reason that we wanted to do it logistically, so that we can get more people that are interested in these issues of diversity to be available during those days.
And Dr. Parivar said, what is the structure of internal medicine diversity task force? Do you work with a committee or one or a few faculty leading this effort, and are residents, fellows, and medical students involved?
Yeah, so I lead those efforts, but I work very closely with Dr. Jassel, as well as Bill Frederickson as well. And there's multiple people that I work very closely with to make a lot of these things happen. The other thing that's been very helpful, there's a chief resident that part of his or her job is basically to help promote some of these things. So we work collectively. And that's why I highlighted Janet Ma Janet Ma, she's the chief resident this year, and part of her responsibilities is to help us improve our diversity efforts. And notice how we concentrated on things besides just race and ethnicity. Gender was an important issue that we wanted to address. And I think within 3 years, we've done a relatively good job of making things a little more equal between the two groups.
And then Dr. Greco was wondering if the clearinghouse for volunteer opportunities, especially in Imperial County or among underserved populations in San Diego, that you're aware of.
The clearinghouse, I'm not familiar with that one. I mean, I can tell you that at least within the Division of Cardiology, we go to Imperial. There's about 5 of us that go to Imperial to provide cardiac care at El Centro Regional Medical Center, as well as Pioneers Memorial Hospital in Brawley, and also at Imperial Cardiac Center. So those are 3 main sites in Imperial County where our faculty from the Division of Cardiology participate in. I know there's been a big push by the Clinical Integrative Network, right? Run by Dr. Friedman, Larry Friedman, to try to get more specialists to go to Imperial and provide care out there. So hopefully with these changes and the CIN and the ability to do telehealth can help bring some of the subspecialists to rural communities out east.
And then Dr. Nelson was saying dermatology is a pretty small department. We don't have the resources to send representatives to meetings and other resources. Do you have any suggestions for the?
Yeah, so I would say that there's a lot of strength in numbers, right? So, for example, I can just tell you that this last meeting, the SNMA meeting, that it was supposed to happen next week in Cleveland, we were able to partner with the School of Medicine, right? The Office of Diversity and Community Partnership, also partner with the Pediatrics Department, and partner with Radiology as well. So when you have 4 different groups together, and you're able to purchase the exhibit booths, for example, the cost becomes a lot more reasonable. So the things that you're more concerned about would be transportation costs for the residents and lodging. Now, fortunately, there's some scholarships available through the School of Medicine to help offset some of that cost of transportation. But I would say, like, and those would be like more the bigger meetings, right? But there's a lot of activities happening here in San Diego in which there's very little cost in terms of transportation or anything like that. It's just basically doing activities within the community and having a point person so that we can connect with that person and say, hey, you know what, this is what's happening. Do you think your residents would be interested in participating?
Thank you. And I think the last, maybe second to last, Dr. Gallo was wondering if you could comment on the IRA CDA program.
What is that program again?
Aracta. You familiar with the Aracta program here at UCSD?
No, I can't say. Who runs that?
Joanne does that as well. That's more for the graduate students and for research fellows. We have an Aracta fellow in our department. It's the Inclusive Research for Teaching a Diverse Nation. I think that's what it stands for. So, yeah, it's just another pipeline of supporting racial diversity at our institution. So glad to tell you about it.
Yeah, no. So I know that Dr. Trejo and Bob Ross, they've been doing a lot of work on that as well. But I'm not too familiar about the work that particular program. I know, for example, that John Trejo runs the the faculty portion of the Hispanic Center of Excellence, so that's a large grant that is divided between the School of Medicine for, again, the medical students get a certain portion of it for mentorship aspect of it and career development, and there's another component for faculty retainment. And that's actually a really nice grant in which junior faculty can get involved with, and it helps pay some of their time so that they can do some research and pairs them with mentorship. I've been involved with that one. And I think that grant still has another 2-3 years left on it.
It looks like the last comment over here from Dr. Schneider. Earlier in the presentation, you made reference to a particular challenge encountered more frequently in our veteran population, which is the PTSD-related heightened bias some veterans carry based on their military service. Are you aware of particular resources for attending and resident providers working at the VA regarding tools or methods for dealing with these complex issues and for de-escalating patients with a higher potential for overt verbal and physical aggression?
You know, that's a great question, and that's what I've been asking as well. In talking to Charlie Goldberg, right? We were talking about some of the allies, some of the people that I work with, right? So Charlie has been wonderful at the VA, and he's been instrumental in terms of getting some of the resources for our residents and our medical students so they can help deal with some of these microaggressions that happen at the VA. I don't know about faculty and those type of resources that you could get at the VA, but I can certainly check with Charlie and pass those on. I don't really see patients at the VA, so I can't tell you exactly how that happens. So what are they available? But I can certainly check with Charlie since he's my contact person at the VA.
Right, well, it doesn't look like there are any other questions. Dr. Schneider said thank you for that. He would appreciate that. And then, but thank you, Dr. Castellanos, for joining us today. This is a great talk. It's wonderful to see all that's being done at UCSD to promote diversity. Thank everybody for joining us this morning. For those of you who came in late, Paula, if you could put the QR code back up on